Well, hi, everybody. My name is Garrett Schmidt, and I'm managing editor for BBC Exhibit Hall. And I'd like to welcome you to today's live webinar hosted by Roji Health Intelligence. And it's titled The Ultimate Guide to APP Reporting for ACOs. There's a lot of really good information. I've had a sneak peek on this presentation, and there's a lot of meaty stuff in here. So looking forward to hearing from these guys today. A few items of note before we get started. Everyone is joined today in listen-only mode, so it's a traditional webinar format. We can't see you, we can't hear you, but we do want to hear from you. So if at any time during the webinar, if you have a question, we will have a Q&A towards the end that we're going to ask as many of those as we can. So you have a little control module, and there's a questions area on that. If you would ask your questions through that, then we'll get to, again, as many of those as we can. And you don't have to wait until the Q&A to do that. Just anytime, go ahead and ask that question. And then finally, today's session is being recorded. So what's going to happen is when we're done here, I'm going to send out, probably later on this afternoon, I'm going to send out an email to all the registrants. So even for those who weren't able to actually attend today, and it will have a link to the recording as well as to the slides for download and some more information there. And without further ado, I wanted to introduce our presenter today, Mr. Dave Halpert. He's a great guy. He is the Chief of Client Team at Roji Health, and he's going to be our guide today. So Dave, I'm going to turn it over to you. Welcome.
Thank you, Garrett. Thank you all for coming today. Good afternoon for those of you in the Central and East, and good morning for those in Mountain and West. Today we're going to be talking about the ultimate guide to APP reporting for ACOs. And let me...
Uh-oh, your slide's not behaving?
There we go. All is well. All right, so this presentation's for health systems and medical organizations that are either participating in an ACO or considering participating in an ACO. We're looking especially for ACO board members. If you are an administrator at a hospital or a medical organization that is either in an ACO or considering joining one, quality and compliance officers, and information and technology specialists. Both the quality and the IT folks are going to be critical in APP reporting, and so we hope that we are able to illuminate those of you on the call with this. All right, we're going to cover what the APP is and how it differs from the CMS web interface. We're going to talk about how health equity and quality are intertwined by CMS in APP reporting, what all patient reporting really means in a multi-EHR network, the arithmetic behind some of the quality measures as we're looking at a provider network with multiple practices, multiple EHRs, and how that will tie into your best plan for data aggregation. We're going to close off by looking at how to evaluate and improve your data once it is aggregated, and then strategies for continuing to improve outcomes and to reduce costs. A little about us. We've been in business since 2002, and we provide value-based care technology and services to improve outcomes, improve cost performance, and ensure equitable health care amongst our clients. Our powerful tools are meant to identify patients with persistently poor control or high-risk outcomes and target health interventions for them. In other words, we want our clients to be able to see who their patients are that are going to be potentially problematic, have high costs, poor outcomes down the road, and to get in touch with them before they hit that point. So we want to engage physicians and other clinicians on truly meaningful clinical improvement for patients. All right, so let's get into the content here. What is the APP? Simplest terms, the APP is a quality reporting method for alternate payment models, which are APMs. APMs are any sort of risk-based reimbursement models, most notably like ACOs. And the APM performance pathway is the APP. So because that is CMS coming up with these, we have an abbreviation within an abbreviation. So APM performance pathway. The purpose of the APP is to ensure that quality is being measured for all patients. There are three measures that are actively for reporting in the APP. The first is a hemoglobin A1C poor control measure for patients with diabetes. Second is a preventive care and screening measure about screening for depression and follow-up plan. And the third is for controlling high blood pressure. It's not in the title, but that measure is for patients who have hypertension. And these are measures that are going to be widely applicable, and that's why they're selected here. There are a couple of measures that are calculated off the books, I'll say, by CMS, where they will look at their claims data and they will calculate your rates for hospital-wide 30-day all-cause unplanned readmissions, and they'll also look at risk standardized admissions for patients with chronic conditions. So if a patient has a certain chronic condition, how often is that patient in the hospital? In addition to those two, there is a CAPS patient experience survey, and that is part of the APP as well. So all patients is not hyperbole. Pandemonium. All patients, regardless of coverage, are included. So it could be patients that are not just Medicare and Medicaid and Medicare Advantage, but everything, whether it is public, private, out of pocket, all patients are meant to be included, must be included in the APP. What that means is that the quality reporting denominator shifts. So in the CMS web interface, as we all know, you've got 248 patients in a sample per measure, and you need to report on each of those. And what that means is that you have to aggregate data from each EHR. There are just simply, with the CMS web interface, what a lot of ACOs are able to do is they're able to have a series of nurses go out to each individual practice, ensure that if there is one of those patients on that 248 patient sample, they're able to essentially audit charts and determine what is the response for that patient for that measure. When you're looking at the APP, you're looking at all patients who, let's say, have diabetes and have been seen. This is potentially thousands and thousands and thousands of patients. And so the idea of abstracting charts is not something that is going to be feasible in this situation. And so you really do need to be able to capture that information within each EHR and ensure that it can be reported outbound. So why the big shakeup? Why put so much more effort into the quality reporting piece? The first is that it aligns ACO reporting with the merit-based incentive payment system, which is MIPS. The quality payment program has two tracks. One of them is alternate payment models. One of them is MIPS. And so this helps to align the way that people participate in the quality payment program overall. It also ensures that measurement is consistent, because APP measures are also the same measures that are used in MIPS. And including the entire population more accurately measures performance. It also illuminates health equity disparities. A little more on the health equity and the APP connection. Health equity is one of CMS's 6 pillars in its overall strategic plan. And so APP reporting highlights health equity gaps. Each of those 3 measures that is reported, and then the 3 that are calculated outside of the active reporting, those are all markers for improved outcomes, and they all provision for health equity. And so the APP facilitates a single high standard of accountable care for all patients, rather than having one set of patients get the top-notch care. This is really looking now at everybody. There's a little more to the story too. For the CMS white paper on health equity, CMS does not have an ability to collect any data on health equity. It's something that is out there, but it is unknown. So this strategy is focused on getting providers to collect additional data to ensure equity. And it's also a big reason why CMS is not backing down on all patient reporting. There had been plenty of lobby, and it has been pushed back. It was, those of you who have been following the legislation know that it was going to be starting this year, but has been pushed back to 2025 as a mandatory piece. And as I said, the CMS web interface is going to sunset in 2025, but your APP transition should begin now. And we'll talk about why. So there are a couple of significant APP challenges for ACOs. The first is that your initial thought may be, well, you can just take the scoring files, the QRDA 3 files together for each of your EHR installations and come up with the right metrics for CMS. But that does not work. It produces invalid numerator and denominator calculations. So let's look at an example patient. Patient John Doe had an A1C done today at a practice using we'll just call it EHR1. Now in 6 weeks, let's say John Doe gets a second A1C done at a practice using EHR2. So the way the measure works, you are supposed to report on the patient's most recent A1C value to determine when they're aggregated together if the population is overall in control. So if you add up the QRDA 3s from practice 1 or EHR1 and EHR2, you're going to have John in there twice. And John is not there twice. John is a single unique patient. So, fact 1, the APP measures require patient-centric results. Fact 2, they must include the entire population. Fact 3, you do get claims data from CMS, and you'll continue to get claims data from CMS, but that only includes Medicare patients. So if you're looking at the APP, or if you're looking at APP reporting and you're trying to get information for all of your patients, it's not something that you're going to be able to do with claims data. Finally, fact 4, there is no unique patient ID number. For ACOs for ACOs with multiple organizations, you're not going to have, it's very unlikely that you will have the same MRN for patients. There is not a standard number that patients that you can use to identify patients. Social Security number is often not provided anymore. And speaking from experience, even when it was, let's say the quality was not as high as you would like it. It's just simply not a good criteria for matching patients. And so that leads us to this inevitable conclusion that to track a patient across the continuum of care, your ACO must aggregate its data. To do that, you've got to overcome 3 technological hurdles. The first one, obviously, is the aggregation itself, establishing the true denominator. So you can see in my very scientific graph over here, if we have 2 EHRs, EHR 1 and 2, you cannot simply add them together because one patient, the John Doe from the previous example, is going to be counted twice. So you need to make sure that you are looking at patients uniquely. And that means that you must match patients across systems without a matching medical record number, without a social security number, without any sort of other unique identifier. You're going to have to do it on your own using some sort of looking at patient name, address, zip code, date of birth, all kinds of things like that, and to try to figure out to ensure that the patient that you were looking at from EHR1 is the same or is different from the patient in EHR2. And then from that, you're going to be able to correctly calculate denominators and numerators for measures. Obviously, there are going to be some issues with data quality. There are major performance implications for ACOs who have underserved populations. When you're reporting for a set of Medicare patients, you're looking at patients who have the ability to go to a provider and who have limited ability or a limited payment that will go along with it. When you're looking at underserved populations, you are looking at everybody, and so people's access to care may not be as good, and it may only manifest itself once you have a poor outcome. So CMS is looking to incentivize APP reporting, so that's good, and I'll talk about that in a moment. But your responsibility is to ensure front-end data collection of social determinants of health. That is going to help you target outreach to patients before they impact your ACO metrics. In other words, people who are not coming to the office as frequently, perhaps because they're self-pay, they don't have the ability, they don't have transportation, they don't, housing is insecure, food scarcity. These are people who are going to be included in your ACO metrics, but there is going to be a, you need to be able to get that information on those patients so that you know who they are, so that you can help before there is an issue down the road. So, as I alluded to, CMS is incentivizing APP reporting. Doing that in a few ways. First, they're easing performance standards. So the reporting requirement, obviously 70% of the eligible patients is the data completion threshold across 3 measures. Well, the web interface has 10 measures, but only 248 patients. It is definitely not accurate to say that it's going to be easier to report in the APP versus the web interface. So one of the things that CMS is doing, both because it is going to be a challenge on the data aggregation front, and also because you are reporting on all patients, not just the Medicare patients, the outcome measure performance standard is only the 10th percentile of the benchmark. Whereas in the web interface, you need to achieve the 30th percentile of the performance benchmark, just like you do in all of the other measures. So you have a little bit of an eased performance standard on the APP, and that's in 2023. In 2024, you still have that 10th percentile of the performance benchmark that you need to meet for the outcome measure when you're reporting in the APP, compared to the 40th percentile of the performance benchmark when you're looking at the web interface. And again, the other measures are all 40th percentile. So you are really getting I don't want to say a break, but you are getting some eased performance requirements for transitioning to the APP. There are also some additional 23 and 24 incentives making your transition bearable. The first is that there is a health equity adjustment for ACOs with underserved populations. That translates into up to 10 quality points, and they look at, when they're looking at underserved populations, they're looking at patients that are dually eligible, and they're also looking at what is called an area deprivation index, which is, it was flagged in the 2023 final rule. It's out of the University of Wisconsin, and it's exactly what it sounds like, where it's by zip code and drilled down into some other locations as well. And so that can lead up to 10 additional quality points. There is also a sliding scale for quality performance. So it is no longer going to be all or nothing. You're going to still be able to share savings even if you do not hit performance targets. So CMS is trying to actively move people into the APP before the mandatory sunsetting. There's one more thing that has come out recently, and that was the end of the 5% APM lump sum payment left the ACO world cold, but wait. The Consolidated Appropriations Act of 2023, sometimes it's referred to as the Omnibus. It was actually just signed into law this last week. It provided a 3.5% payment for the 2023 performance year. So not quite the 5% that we had before, but certainly enough to make this a potentially game-changing thing. So beware, that lump sum payment is going to mean competition from new and existing ACOs. Some were considering waiting until there was an APM lump sum payment that found its way back into legislation before starting a new one. This is going to give people the incentive that they need to begin early. So what you need is a step-by-step guide to achieve reporting success in the APP. So you've got a 4-step pathway. The first, and you can imagine it, you're building from the ground up. The first, you need to get the expertise and the infrastructure that you need for all patient reporting. This is not going to be something that you are going to be able to perform yourself particularly easily. You need to, and once you've done that, you need to identify all of the data sources in your network and confirm their export capabilities. Then you've got to choose your reporting method. There are 2 different ways to report. And then finally, leverage your success. You've put all of the work into this. Let's get more out of it than just simple quality reporting. So, taking these one at a time. Expertise comes from experience. So an APP reporting infrastructure takes an ONC certified clinical data registry that has experience doing all of these things. They've got experience reporting both electronic clinical quality measures and the MIPS clinical quality measures to CMS as a qualified third-party intermediary. Registries have been allowed to report for CMS programs since 2008. And they have allowed, and then the under the previous programs, what's called the MIPS legacy program. So PQRI, PQRS, for those of you who have been in the game a bit, will remember those. And now MIPS beginning with 2017. You need someone with experience who's aggregated data from many different EHRs. This is not a nice to have, this is a must have. Your database must be a patient-centric database. Each patient is unique in the ACO. That means you're going to need somebody who has experience matching patient records across groups without the benefit of a shared MRN. And it's going to be challenging. There are patients whose names are entered differently from one system to another, and you're going to need someone who has the experience doing that. And then finally, using that data, using that data to create analytics at cost and quality, because as I said, you're going to need to put in a significant amount of work, but once you do, it can really work for you if you take advantage of what you've already done. So the next thing you need to do is you need to identify the EHRs that are in your network and confirm what they are able to send out. This background work is absolutely critical. Surprises will always equal delays. So if you're not certain if there is a surprise, it's going to mean a longer time. So for each system, you should know at first the basics. What's the name of the EHR? What version is it? Is it ONC certified? Then you need to look at connectivity. Are there commercial lab interfaces? Are there export capabilities? Are they able to send QRDA1s or just QRDA3s? Are they able to send neither? You need to look at workflow. Are there custom templates? Is there entry of social determinant of health information? And then finally, who manages the system? Who do you contact if there is an issue? If you're examining the output of the files that you're getting from the EHR and they're not as you expect, where do you go? So you need to avoid this one pitfall, and your clinical data registry can help avoid the QRDA3 pitfall. There are 2 types of QRDA files, and I apologize if this is review for some of you, but it's important to restate. QRDA1 files are patient-level measure details. QRDA3 files are aggregate score files. So a QRDA3 file will have the measure, the title, the number of patients in the denominator, the number who have been reported in the numerator, and what the performance met, performance not met, denominator exceptions. They have no use in data aggregation. So if you are asking your EHRs, are you able to export QRDAs? There's another follow-up question that you need to ask, because if they can only export QRDA3s, they are not going to be able to give you information that you need to aggregate data. So your clinical data registry can help. So let's say that EHR does not have the ability to do a QRDA1. There are still options. Your CDR can help. So that's what I've tried to illustrate here, is that our clients have, some of them have varying levels of technological infrastructure. And so we are able to take the QRDA1s from them, but then there are other practices where they're sending us pipe delimited text files, HL7 files, and it's something that can be aggregated together, but you're going to need a trusted partner and able to be able to do that. There are two CQM clinical quality measure reporting options. Whether you're looking at electronic clinical quality measures or MIPS clinical quality measures, the differences are they're the same measures. All patients are required, but those of you who know about ECQMs know that they are done behind the scenes. It is something where the information is scooped up by the EHR. It's based on a pre-built query, and it is able to put up that information about those measures so that you can submit them. The big difference, though, between ECQMs and MIPS CQMs is that ECQMs do not allow any intervention. They are hands-off. It's the end-to-end reporting wherein there is no manual intervention. And that means that there is not an option for alternate workflow. If you're not putting the information at the point of care, in the spot, in the EHR, that is going to be used to calculate the ECQM result, you're not going to be able to do it. MIPS CQMs do allow alternate workflow though. So the MIPS CQM, they are going to be, they're going to be a little more options, or excuse me, a little more flexibility and safety nets, but they are going to require some additional effort. The ECQMs, they're automated, but that carries risks. So reporting configurations clash with real world workflows. And I'll give an example. We have a client, and they had, it didn't make sense how few blood pressure results we were getting. It's something that we expected to get, a very high rate of them, and we just weren't. And after a lot of back and forth, we realized that this client had created a bunch of custom templates, one for each of their specialties. And so while the EHR was pulling from the blood pressure table, it was not pulling from cardiology dash blood pressure and dermatology dash blood pressure all the way through the end of the alphabet. So it is, they can be risky in situations like that. It's limited to the information in those predefined fields, and it's only possible really if everybody can produce QRDA1 files. MIPS CQMs offer that additional flexibility in the safety nets, but it's going to be harder. So the question you have to ask yourself is, can all of your EHRs produce high quality, accurate QRDA1 files that you can actually trust? I mean, if they can, then ECQM is probably the option, but if not, the MIPS CQMs offer some of those safety nets that you're going to need. Finally, once you have aggregated all of this data with your partner, you can do something with it going well beyond quality reporting. You need to leverage your success. So you've got a new infrastructure. It's time to make some new opportunities with it. The quality reporting is just the entry-level benefit to the data aggregation. It's time to capitalize on your investment. So the quality measures are the place to start. Performance shortfalls in those quality measures can illuminate opportunities for you. So if you did not score as well on the A1C measure for patients with diabetes than you would have liked to, look at the reasons why. Are treatment plans changing for patients with high hemoglobin A1C? Or is the patient coming in just as they do, but they're on the same drugs? There hasn't really been any change. Are blood pressures really high, or are they being taken improperly? Some of the analytics that I'll be showing you at the end of this highlights some of that, where we had again a client story where we were showing blood pressures compared by provider, and the client realized immediately that it was not that the providers were not providing adequate care, it's that the new staff at the office had not been trained on how to correctly take a blood pressure. That is to say, feet on the ground, back supported, don't talk to the patient while you're taking the blood pressure. And so what was happening is that they were getting artificially high blood pressure results. And that can hurt you in quality measures. And it also is sort of a red herring if you're trying to figure out how to improve care. You're chasing after something that isn't really a problem because you haven't measured it correctly. And then finally, does fewer depression screenings stem from a lack of available in-network mental health care? That's a huge thing that you are going to need to know. And it may be something where it is not a quality measure that you're pursuing. It's that you need to find mental health professionals and bring them into your network. So, screenshot here from some of our analytics where you can look at how those quality measure shortfalls can be turned into improvements. So you're looking at patients who have a certain condition, and there may be something additional with that condition. So perhaps they are the patient is obese and has not been referred to a nutritionist or a dietitianist, or they are on a certain type of medication, but there isn't any difference in the results. You can set this up so that you can see your results across time, so that you can see if your intervention is working. You can do this as something that you will roll out then in the future, or you can start with everyone right away. And then finally, you can graduate to advanced topics. So you want to find the patients who are persistently poor controlled in those intermediate outcome measures. Those are the measures like the A1C and the blood pressure. They're not, a high A1C or a high blood pressure are not themselves bad outcomes, but they are indicative that somebody is going to have a poor outcome down the road. They're intermediate outcomes. So you need to identify these people before they become an issue. They're going to be more likely to require care in the hospital or in the emergency department. And what you can do with aggregated data is you can see where these patients have gone, where they have not gone, and you're able to be proactive. The data is actionable because you know that these patients have, let's say, a high hemoglobin A1C, and they have not been to the nutritionist that you have referred them to. The benefits are going to multiply. So as your patient's outcomes improve, so does your measure performance. If you are able to target certain sets of populations that have a certain clinical subset in there, like say they are, they've been on the same there hasn't been any change to their medication, they haven't been referred to a specialist to help manage. Let's say if they have heart failure, they have not managed, or they have not seen a cardiologist. So the patients are going to get better, and you're going to also then see better measure performance. And that also is going to mean fewer costs down the road. So once you've identified these patients, you can look at the difference between providers and sites, and then you can even branch out. So here we're looking at data aggregation and proactively engaging patients with a certain either a chronic condition and some of the things that go along with that. So these are patients where there may be some sort of social determinant of patients who have, let's say, diabetes and who have social determinant of health indicators, or patients who have diabetes and they have additional chronic conditions, but there has not been a change in medication. So you're able to look specifically at who these patients are and why specifically they may have high intermediate outcomes, so that you can create a targeted approach to reaching out to them. It's not just a question of saying, oh, here are your patients with high hemoglobin A1Cs. That's not useful. You can look that up on your own. But what you need is something where you are able to see across the network everything for that unique patient, and then drill into a targeted subset where your efforts can actually produce results. Once you've achieved that, it's possible to branch out. You can look at procedural episodic costs vary by provider and site as well. So we've been talking about chronic conditions, but obviously procedural episodes are going to be a big driver of your ACO's costs as well. You can investigate the root causes of this persistent poor control. And that may translate into understanding your population's social determinants of health needs. And so you will be demonstrating a single high standard of care, and you're going to be able to then engage other private health plans and value-based care initiatives. There isn't any need to stay just in a Medicare ACO. Once you've aggregated your data and you're demonstrating high quality care across the board, you're going to be able to engage other health plans as well. So here's something that I had mentioned previously about looking at comparing intermediate outcomes by provider and site. And so we're looking at diabetes here. The example that I had given previously with blood pressure, it looks exactly like this, and that client was able to see exactly who the providers were that where their blood pressures were out of that middle grouping, and the light bulb just went off. They said, "Oh my gosh, this is the new staff. They haven't been trained," and it was something that they could take immediate action on. This isn't to say that a provider who has patients with a high intermediate outcome is a bad provider compared to someone who is not. But these are the analytics that you're going to be able to use to start asking yourself questions. They're going to be, each of your practices are going to have different sets of patients in them. And so one group may need a lot more support from the ACO than another, but that's good to know. It's not going to be necessarily the person who has more of a concierge practice compared to the community practice. You're going to need to know not just who the providers are, but you can start asking the questions of why. Why is treatment varying? Why are patient intermediate outcomes varying? There may be a very good reason that has nothing to do with the provider's quality. It may just be support. Can also do this by looking at procedural costs by provider and site. So if you're starting to look at, let's say, a cholecystectomy, you want to know who your providers are who are doing them, and you want to know if there are more what we call notable observations, which are not necessarily mistakes, but they are things that are potential drivers of cost. So you want to know if your provider's costs are sort of outside of that group. There may be a reason for it. We've seen groups where there is one provider who, the cholecystectomy example, would always do them open rather than arthroscopically. And when asked, it turned out that he wasn't actually doing it open for any reason other than that's how he had always done it. And so this helps to set the stage for asking those questions about why costs are higher for one person compared to another. It is also going to be great once your data is aggregated, where you can see how different facilities will tie into your costs as well. So you'll be able to see with aggregated data where patients are able to go to, let's say, a nursing facility and come out sooner and healthier, as opposed to one that is, just keeping the patient for the entire 30 days or however many allotted days that they are able to keep that patient and just keep that fee-for-service money rolling in. That's going to be a great way for you to use that aggregated data to help see where to develop your referral networks. And so we are to the end of the presentation here, and we're going to have some time for questions and answers before we wrap it up here. So Garrett, I think this is where I turn the ball over to you.
That's right. That's right. And this was, I don't know about everyone else on the line, but this was very informative. I got a lot out of this. And there are some questions that came in. So if you do have a question, please go ahead and submit it now. And it is you use your control module there. There's an area for questions. So it's not through the chat. It's actually through the questions. And we'll get to as many as we can. Okay. First question, and these are in no particular order. If all of our providers are not using the same EHR, will we be able to submit ECQMs?
Yes, you can. Even if they're not using the same EHR, you are going, if they can generate those QRD1 files, and those files are matched so that you can see that each individual patient is being submitted uniquely, you definitely still can submit ECQMs.
Wonderful. Next question is, let's see here. Well, what is the biggest challenge with respect to data sufficiency for APP reporting versus traditional MIPS?
Oh, that's a good one. I would say the biggest thing that makes APP reporting more challenging than traditional MIPS in terms of data sufficiency is that it's actually one of the reasons that CMS has taken so many steps to make to sort of get away from traditional MIPS, is that there are so many measures that you can report in traditional MIPS. You have so many options, and you are able to cheat is the wrong word, but you are able to game the system a little bit and select measures to report where it is either easy for you to collect the data, or it's or you're going to do well, even though it may not be a true measure of the kind of care that you actually provide in your practice. And the APP does not allow for that. You've got those three, and those are the ones that you must do, and you don't have. And there's just nowhere else that you can go. There isn't something that you can do to augment your score if you don't have the information that you need for those measures.
Wonderful. Next question is, do the three required MIPS measurements, or are the three required MIPS measurements required by all specialties or just PCPs? For example, why would an orthopod ensure the patient is screened for depression using the AWV? Doesn't that fall into the purview of the PCP?
It does, and this is what ACO. This is the whole issue behind the APP and the aggregated data, is that you are reporting as an ACO that your ACO did something performed some sort of quality action for the patient. So if the PCP has screened that patient for depression, no, the orthopedist does not need to do it. It's already been done. And that's why adding the results from different practices doesn't work, is that, of course, the orthopedist wouldn't do it. And that's what we see frequently. And that orthopedist example is a great one for, let's say, the diabetes measure. The orthopedist is not going to be managing that patient's hemoglobin A1C, but it is entirely conceivable that the orthopedist is going to diagnose that patient who is there for a footwear evaluation with diabetes, which would make them eligible for the measure and ruin your valid results if you tried to add everything up. So you're all managing the same patient, and so that you are reporting then that one patient had the action performed, most recent A1C by the primary care provider, even though they were seen by the orthopod.
Got it. Okay, we'll keep moving here. We do have some more questions, but please, we want to hear from you, so please ask your questions. Next is, how likely is it that CMS could change the three measures in the APP down the road?
I suspect that they are going to be, they may add to them. Those three measures provide a very unique core. And they're very similar to what's already in the CMS web interface. Obviously, the A1C and the blood pressure and the depression screening, they're all part of this already. I don't think that they will be removing any of those three. I think what's more likely to happen is they may add to them in future years, perhaps with, let's say, preventive care and screening measures, cancer screenings, potentially tobacco use as well. But those three measures are sort of CMS's core.
Got it. Next question is, I realize we need to report on all payer data, but is the ACO responsible for improvement in those measures too?
Yes. Yep. The measures are reported to CMS. Now, CMS is not going to be able to calculate any sort of cost metrics on all payers. They can only calculate the cost and the readmissions and such things when they have claims data to do so. But you are required in the APP to report on all patients, and the results are, that's how you are judged, is the results for all patients, not just Medicare.
Great. Next question, keep on rolling. Is the non-ambulatory denominator exclusion for the fall risk screening measure no longer used?
That's not part of the APP. That's part of the CMS web interface.
Okay. Very good, very good. And the last question here, which sounds so much like we wrote it, but it actually came in from an audience member, is where can ACOs direct an RFP to Roji Health Intelligence?
Well, I am so glad you asked. I'll tell you what, I will go back. I will bring this slide up right now. They can direct it to Dan Cronin, who's on our business development side of things at Roji Health Intelligence.
Very good, very good. And actually, we did have another one come in here. We've got time for a couple more here. How does CMS verify your results of all patient measures if they don't have access to their claims data?
That is a great question. It's the same way they do for MIPS, is that we are required, third-party intermediaries, but also people who submit on their own, they are required to certify a statement of truth that the data that they are submitting is true, accurate, and complete. And CMS does have the power to audit, and they are doing that with, they're doing that in MIPS actually. So even though they are looking at, it's a third-party contractor, and that third-party contractor is going to be able to review results of all patients, and if there is, let's say, a discrepancy between what you have said you have submitted and what you actually have, there could be some serious legal repercussions down the road. Also, as a third-party intermediary, one of the things that we have to do is have a data validation plan in place with CMS and so it's basically where we will send a sample of files back and forth securely, of course, between our clients and ensure that the information that we're getting from them is based on what is actually in the patient record. So it is it's inexact, but it is definitely something that you should be aware of, that they will have the ability to audit, potentially just using a third-party contract.
Very good. Very good. Well, with that, we are going to wrap it up. And so very glad that you guys could join us today. Thank you so much for taking your afternoon to spend with us. As we're closing out, I wanted to encourage you all to stop by the Roji Health Intelligence virtual exhibit booth on vbcexhibithall.com. And here's where you can interact with their team. You can learn more about their resources, kind of really do a deep dive into what they're doing in the value-based care space and learn more about them. And of course, interact with their team as well. And then finally, again, going back to that RFP questions, if you have an RFP that you'd like to submit, or if you want to just get in touch with the team, whether Dave or Dan can help you out there, and their contact information is here on this slide. Now, I'm going to be actually sending out an email later today with a link to this recording, as well as a link to where you can download the slides. So you'll be able to get all this information. But lastly, thank you so much for joining us again. I'm glad you spent your time with us. I know there's a lot vying for your attention. Dave, thank you so much for the presentation.
That's my pleasure. Thank you.
Very good. Well, we'll see you guys next time. Thanks for joining us. Have a good one.